Hi there, nurses. Welcome back. Let's talk about blood pressure. What is blood pressure? An individual's blood pressure refers to the pressure measured within the large arteries in the systemic circulation. Traditionally, we measure blood pressure in the arms and legs, targeting the pressure within the brachial artery and popliteal artery. Systemic arterial pressure is another term for blood pressure, since it measures the pressure within the artery. However, we don't use this term often. The blood pressure reading consists of systolic blood pressure, this is the higher number, over the lower number diastolic blood pressure. So how we get this number? Commonly, we measured blood pressure using auscultation with sphygmomanometer, a kind of BP apparatus, and it is measured in milliliters of mercury. We called it non-invasive blood pressure measurement. And in critical care settings or for critically ill patients, we preferred invasive blood pressure or arterial blood pressure monitoring. Alright, let's see what is this pressure we are measuring exactly is. Okay? Blood pressure is the force of blood on arterial walls with its heartbeat. This systolic pressure here refers to the maximum pressure within the large arteries when the heart muscle contracts to propel blood through the body, whereas the diastolic pressure describes the lowest pressure within the large arteries during heart muscle relaxation between beating and where blood returns to the heart. Blood pressure is remarkably easy to alter and can be affected by many factors. Having said that, we commonly use blood pressure values as a clinical determinants of our therapeutic decisions. Physiologically, blood pressure corresponds directly to these factors: cardiac output, arterial elasticity, and systemic vascular resistance. For better understanding, here is the illustration of how these factors correlate to blood pressure. Blood pressure is mainly determined by the cardiac output and systemic vascular resistance. Cardiac output is the amount of blood ejected by the heart per minute, and which is the stroke volume multiplied by the heart rate. To express this in formula, blood pressure is equal to cardiac output times systemic vascular resistance. I posted a video explaining cardiac output. You can watch that video if you haven't yet for an in-depth understanding of cardiac output. Moving on, systemic vascular resistance is the resistance of the arteries to the blood flow. As the arteries constrict, the resistance increases, and as they dilate, resistance decreases. Systemic vascular resistance is so named to make it distinct from pulmonary vascular resistance, which is a completely different animal. On occasion, one may also find the textbooks making references to peripheral vascular resistance, which implies that the vessels of interest lie in peripheral body structures. Alternatively, some authors prefer the term total vascular resistance. Systemic vascular resistance has determinants. These are the vascular structure and vascular function. Vascular function is regulated by many cell components, including endothelial cells, vascular smooth muscle cells, and adventitial tissues with inflammatory cells, as well as the autonomic nervous system. The interactions among these physiological variables affect vascular function. Vascular structure, of course, is the anatomical composition of the blood vessels, either normal or pathological structure. Therefore, factors that influence vascular resistance in individual vascular beds determine systemic vascular resistance. Mechanism that cause vasoconstriction increases systemic vascular resistance, and those mechanisms that cause vasodilation decreases systemic vascular resistance. Although systemic vascular resistance is primarily determined by changes in blood vessel diameters, Changes in blood viscosity also affect SVR. Alright, maintaining blood pressure within normal limits is essential. Normal blood pressure is within 90/60 and 129/79. Blood pressure between 140/80 mm per mercury to 159/99 mm per mercury is classified as stage 1 hypertension. Stage 2 hypertension is the pressure between 160/100 to 179/109. Hypertensive urgency describes a blood pressure greater than 180/110 mm per mercury. Hypertensive emergency refers to the very high blood pressure that results in potentially life-threatening symptoms and end organ damage. Hypotension, on the other hand, is a blood pressure less than 90/60 mm per mercury. It is crucial for the body to be able to adjust to acute changes in blood pressure and for the patient to receive medical treatment or lifestyle adjustments for chronic variation.